poisoning and overdose. How does that apply to you guys? What are some things you're thinking? What are some potential patients? What do you think you're going to get dispatched to? What pops into your head?
Possible suicides, attempted suicides.
So intentional overdoses.
Yeah.
People trying to kill themselves. Good. You're going to run lots of those. What else?
Parties.
Parties. So alcohol.
Alcohol.
People taking the wrong drugs.
Or like
Okay. Like illicit drugs or.
Like prescription drugs not prescribed to them.
Okay. So recreational drug use.
drinking stuff under the sink.
So little toddler getting grandma's medications.
Drinking stuff under the sink like me.
Little kiddos getting into the stuff under the sink. Okay, good. Those are, I've been dispatched to every single one of those. Definitely happens. One thing that nobody shared here, poisonings. What about industrial accidents? Companies who work with lots of chemicals, cleaning agents, swimming pools, chlorine, things like that. There's a lot of big, high-powered stuff, which is a little bit more poisons that we're talking about. So substance which, when introduced into the body in relatively small amounts, causes structural damage or functional disturbances is a poison. Okay? Anything basically that is harmful to the body if ingested. So suspect poisoning anytime there are GI signs and symptoms. So nausea, vomiting, diarrhea, and pain. That's basically your body trying to get rid of a substance that's been ingested. Altered level of consciousness, seizures, unusual behavior. Pupils, remember, especially anytime there's altered LOC, pupil changes. Okay, salivation, sweating, other signs, symptoms of disturbed autonomic nervous system function. This is the big key here. Generally, when we're talking about altered mental status and substance abuse, anything that interrupts the autonomic nervous system, which, what is it? What does the autonomic nervous system regulate? Here's part of it right here, right? All your rest and digest type things, okay? Your pupils, your GI, digestion, that type of thing, which is why you're going to see the nausea and whatnot. Respiratory depression, which is obviously altered breathing. Burns, blisters of the lips, and mucous membrane. So look at the mouth itself, see if it appears that maybe they had some sort of caustic substance. And unusual breath odors. Alcohol is usually probably the biggest one, ETOH, that we can smell on the breath, but there may be other things that you smell on your patient's breath. Treat the patient, not the poison. Proper support of ABCs is the first step in all poison management. Try to determine what, how much, how long ago, what has already been done. Do they have any sort of psychiatric history and any underlying illnesses? I ran a patient in his mid-20s, male, found unresponsive in his garage. Next to him is a white styrofoam cup half filled with an orange liquid. Okay? How do we know what that is? How do we know what to do for it? Okay? We may not know right away, and so we're going to treat the patient, right? I don't need to know what he took to assess his ABCs and determine whether I need to breathe for him or what I need to do, right? I can initiate treatment. But what do you think I did with that orange cup? Yeah, I picked it up, I put it in the cup holder in the front of the ambulance, and we took it to the hospital. The lab at the hospital can run tests on those substances, and they can try to figure out what it was. What types of things do you think people keep in the garage that might be poisonous?
Antifreeze.
Which is what this guy was antifreeze. But what else? I mean, there's paint. Sometimes there's wood thinners. There's spray paint cans. Carbon monoxide poisoning. He could have turned on his car. There's a whole bunch of chemicals in the garage, right? So while we may suspect that it's antifreeze, it's a good idea to take it to the hospital, see if they can determine what exactly it is. Does anybody know what the treatment is for antifreeze ingestion? IV alcohol. Okay? When in doubt, assume containers were full. So I had half a cup of antifreeze. Do I know whether that was his first cup that he drank I don't really, but I'm going to at least assume that, he drank a minimum, probably half a cup. If I could find the actual container of antifreeze that he used, and let's say it's half full, then I'm going to assume that he drank all of that.
Would that have
Okay.
been a suicide attempt?
That would have been a suicide attempt.
I don't really know.
Okay? Assume containers were full, the entire contents were ingested. Okay? Sometimes we try to get a pill count. For example, I had a guy the other day who had wrecked his truck in a neighborhood. People came out, heard the commotion, called 911. We get there. He's altered in his truck. In his truck, we find 3 or 4 different pill bottles. Some of them have pills in them, some of them don't. We look at the date on the pill bottle, try to determine when it was filled. Usually it says take, 1 pill every 4 hours for pain, whatever it is. And we try to do a little bit of math and say, okay, if it was filled 3 days ago, he should have taken up to 12 pills out of his 30, but the bottle's empty. Okay? So we're going to assume that in the last 3 days, he's taken all of those pills, plus whatever else was in there. Okay? You can do a little bit of math, try to figure it out, and occasionally we'll run them, and they were filled last night at 8 o'clock, and it's morning time at 6 a.m., and it's empty. Okay? Sometimes it's that easy. If several patients are involved, assume each ingested the entire container contents. Okay? Always bring sample material if possible. If patient vomits, save for analysis. Okay? If they vomit into a little baggie or whatever and you can keep it, keep it. Most likely, the hospital is going to throw it out, but hey, they may want to check it. Oh, look there. What's the number for poison control? 1-800-222-1222. So, poison centers, they can help you with product identification, poison medication information, advice on management, and education and prevention. Advice on management. Does this mean that you do whatever poison control tells you to?
No.
Why? What is poison control? Who regulates poison control? Who's there? Who are you talking to when you even call poison control? Who knows? That'd be a good thing to know, right? Okay. Well, there's a bunch of real expert specialists who write up what goes into poison control. Okay. Everything's entered into a database with treatments and plans and amounts and all this different stuff. So when you call them, like I'll call them all the time, from the ambulance and say, hey, I've got somebody who ingested, I don't know, I've got a baby who ingested an unknown amount of Lysol cleaner. Okay? And they'll go right down the list. They'll look at Lysol cleaner, blah, 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 and they may ask, is this in the blue bottle or the purple bottle? And you say, oh, it's a blue bottle. And they'll say, okay. And they'll read off exactly what's in it and what you need to watch for. And they'll say, things you need to watch for are vomiting, nausea, vomiting, and respiratory depression. Say, okay. And they'll say, antidote is this, should be available at the hospital. And then they usually will take your name, patient's name, and what hospital you're going to transport to, just so that they can follow up. So they're a really good resource. Our SOC actually, and this is where you get into trouble, just because poison control tells you to do something does not mean you're covered under your SOCs. So you need to know what your medical director allows you to do in regard to poison control. Okay? Per my protocol and my system, I can, basically they let us make our own decision. We're welcome to call poison control, and they said, hey, if it fits into our SOC, if it's something that sounds like you can do it, or we can always call the physician at the hospital we're transporting to and say, hey, here's what poison control said, here's what our patient is, what would you like us to do? And then you may be able to receive a direct order from a physician. Getting an order from poison control is not getting an order from a physician. Okay? It's not the same. Okay, based on route of entry is what you're going to do for it. So if it's ingested, what does that mean? Huh? Okay, yep. Absorbed?
Skin.
Okay, inhaled and injected. Usually with a needle or a stinger, right? Bee stings, that type of thing. Okay, ingested poisons, our goal initially is to prevent absorption of toxin from the GI tract into the bloodstream. Okay, remember it's actually outside of our body till it gets absorbed into the bloodstream. So we're going to give activated charcoal for this. What's our dose for activated charcoal?
2 grams per kilogram.
Yep, 1 to 2 grams per kilogram. Okay, so you need to figure out the patient's weight. What's our time frame for giving activated charcoal? Within the first hour. Okay, usually within the first hour. Once they exceed an hour, we usually kind of lay off on that. Syrup of ipecac is an agent that induces vomiting. Okay, I don't know anybody that carries it anymore, but you can see where it would be somewhat effective. The only problem with it is it's impossible to completely vomit your entire stomach contents. Okay, you can usually only vomit a third to a half of your stomach contents, so a lot of those pills or whatever it is you took are going to remain in the system. You may help them, you may save their life by getting enough of it out of them, but you can't get all of it out. Whereas the activated charcoal, it may cause vomiting, but that's not its primary goal. It's actually going to follow all the way through the GI tract and absorb that medication all the way till it's pooped out. Okay. Side effects of activated charcoal: dark black stools, possible vomiting. Right. Okay. Absorbs toxin, prevents absorption from the GI tract. That's why we give it. Here's how it comes. It could be called Superchar, Instachar, Actidose, or Liquichar. It comes in a couple different containers. Again, generally, we just cut the tip here and let the patient drink it. I don't usually put it in a cup or anything because if they see how black and nasty it is, they won't usually drink it. So if you just cut the tip and let them suck on it, they don't ever see it and they don't know. They know it tastes gross, but they don't know. They usually get it down a little better. Form, it's pre-mixed in water, usual bottle containing 12.5 grams. Just depends on the size of the bottle. Everyone's going to be a little bit different. So dose is 1 gram per kilogram of patient body weight. Usual adult dose 25 to 50 grams. Okay. Usual child dose 12.5 to 25 grams. These are test questions, y'all. They're going to ask you what the usual dose is. Contraindications would be altered mental status or the inability to swallow, or the ingestion of acids or alkalis. Anything that burns real bad, remember, you're better off having it in your stomach, which is used to like hydrochloric acid, that type of thing, versus coming back up the esophagus and damage. Y'all know the burn you get when you vomit, right? Okay, so that hydrochloric acid, your body handles fine as long as it's in your stomach and in your intestines. Once it leaves that, comes back up past that gastric sphincter, it burns, it's irritating, it's painful. Well, any acids or alkalis that you've ingested, such as like bleach or gasoline, it's going to burn too, and bringing it back up, you're just going to burn everything twice. Okay?
Does the charcoal make you throw it up?
It doesn't make a lot of people vomit just because it tastes so nasty, but it is not an emetic agent. No, it is not designed to induce vomiting. The syrup of ipecac is. Okay, it will not bind with alcohol. It will not bind with petroleum products, so gasoline, that type of thing, and it will not bind with metals. Okay, side effects: nausea, vomiting, black stools. Administration: shake container thoroughly, use covered opaque container, have patient drink through a straw. Like I said, we just cut the tip and have them suck on the tip. If patient vomits, dose may be repeated. So Bethany, if you do give it to them and it does cause them to vomit, remember you can't vomit everything in your stomach. So when they finish vomiting, give them another bottle and tell them to drink it again. Okay? What if the patient doesn't want to drink it? What if they said, yeah, I know I took 50 pills, I want to die? What do?
Wait.
You say, here, I want wait for what?
Pass out.
Well, how are you going to give it to them if they're passed out? See right here, contraindications, altered mental status, inability to swallow. So how would you give it to them if they pass out? They can't swallow it, right? What? Can't inject it. It's PO only, by mouth only. So what do? You're in your ambulance. You got a 16-year-old female that says, my boyfriend dumped me, I want to die, so I stole a bunch of pills and I took them all, and I'm refusing to drink that nasty black stuff.
You stick a tube down there through it, maybe?
Okay.
You try to convince them otherwise?
Huh?
You try to convince them otherwise?
Okay, that's our strategy. Okay, in the ambulance, talk to them about it. Okay, maybe you need to be a therapist for a little while and convince them of some self-worth and try to encourage them. Are we going to get in a fight with them and get them to drink activated charcoal?
No.
Probably not. Okay. However, Bethany, you brought up a good point. Once they go unconscious and we show up at the hospital, yep, they're going to put a tube down them and force it down them. Okay. And when I worked as an ER tech, there was a few patients that we didn't wait for them to pass out. We said, well, you're here, you're a minor, your parents want you treated, it's going down. And we literally held them down, put the tube down their throat, and shoved it down. It's not the funnest thing to do. Okay? So anyway, you may have to be a pretty good supportive diplomat with these patients in the ambulance. Okay? Because not everybody's going to voluntarily just drink activated charcoal. Syrup of ipecac, seldomly used, induces vomit by irritating the stomach and stimulating vomiting center in the brainstem. May be helpful if ingestion has occurred within the last 30 minutes. So this works best if it's used early on, but again, you can't get everything out of the stomach. So that's where activated charcoal is a little bit more effective. Dose, 15 or 30 cc's. Repeat once after 20 minutes as needed. Be sure the patient is drinking some water. Should not be given at the same time as activated charcoal. Okay, so it's kind of one or the other. Usually if you want to induce vomiting, initially if you carry both of these, it would be the syrup of ipecac first and then do your activated charcoal afterwards. Again, decreased level of consciousness, seizing or has seized, caustic poisons, and petroleum-based products. You don't want these things coming back up twice because they'll burn you. Absorbed poisons, so dry chemicals, things that you would get on your skin, okay? You want to brush off without contaminating yourself as much as possible, and then wash with copious amounts of water, okay? Liquid chemicals, obviously you're not going to be able to brush those off, so you're going to go straight to water. We don't put neutralizing agents on anything, okay? So just because grandma says butter is really good for burns or whatever it is, like we don't put stuff on patients, okay? Just water. Just wash it away. The biggest concern with these types of poisons is they're out there on their skin, easy for you to contact, okay? So keep yourself safe. You don't want to dust this stuff off the patient into your ambulance, okay? You want to do that off somewhere else. And you don't want to transport this stuff into the hospital because then you contaminate the whole hospital. Okay, so literally these type of patients, we're probably going to remove all of their clothing, make them shower, and then wrap them up in a blanket and take them to the hospital. Okay, I've had people who have been covered with gasoline in a car wreck where the fire department's cut off all their clothes, hosed them off with a hose, and then we put them in the ambulance because we don't want to bring all that stuff with us. Inhaled poisons, remove the patient from the exposure. So carbon monoxide poisoning, they're in their garage, they left the car running. Okay, that's dangerous for you to go in there. We need to ventilate the space first, get the car shut off, and then evacuate the patient from that environment. So maximize oxygenation and ventilation. Again, do not accidentally expose yourself. Injected poisons attempt to slow the absorption. You may be able to do that through venous constricting bands, things that you do for like snake bites, whatnot, depending on the type of snake. Put them in a dependent position. You want to keep the heart rate low so it doesn't pump the poison around as fast. Splinting of the injected body part if it's an arm or a leg, limiting their use of it. can keep it from being moving around. Be careful doing cold packs. So again, somebody gets bit by a snake or a spider, so you throw an ice pack on it. Well, what you do is you drive all the circulation away, but that makes the poison very, very concentrated in that area, and it's going to cause a lot of tissue damage to that area. Whereas if it does get spread through the body a little bit, it's not as necrotic to one little area. Okay, drug abuse, overdose. Substance abuse, self-administration of a substance in a manner not in accord with approved medical or social practices. Okay, so it's using a substance in a way you're not supposed to. So substance abuse causes psychological dependence, physical dependence, could be compulsive drug use, tolerance, addiction. There's several different levels of substance abuse. So psychological dependence forms habits, and substance is needed to support users' sense of well-being. Okay, this isn't necessarily just drugs, right? This could be coffee. Okay, there are some people who, if they don't get their cup of coffee in the morning, their day is just going to be absolutely horrible, even though their day is probably perfectly fine. Okay, it's a psychological thing. Okay, they've built up this dependence on, I have to have my cup of coffee. Okay, I got to have my Starbucks mocha latte, decaf, whatever. Okay, physical dependence is kind of a different step where the substance must be present in the body to avoid physical symptoms. Like they will actually go into a seizure if they don't have that substance in their body. Okay, that's going past the psychological dependence to where they are truly physical dependent on the substance, and it will cause adverse effects if they don't have it in their bodies. Compulsive drug use, use of drug rituals, culture associated with its use become an overwhelming desire. So these are people that are doing it constantly. It's what they want. Tolerance, this is where, because you've been exposed to a substance for so long, your body builds up a tolerance to it. So they require increasing amounts of the drug needed to produce the same effect. So one joint of marijuana used to get them high. Now they have to smoke 3 to get high because the body has built up a certain level of tolerance to it. Tolerance contributes to addiction by keeping user chasing the last high. So the last high was always better than the next high, right? Like they have this, they did the drug, it was awesome, they went on this great journey, you know, Lucy in the sky with diamonds, whatever. Beatles are all happy. Well, the next time they take the drug, it's not so great, so they have to try it again and take even more to reach that same effect that they had the first time. And then guess what? The 4th time they got to do it, it's not going to be great again, so they got to go get more. Or they got to try a different drug, or they got to combine 2 drugs. They're always chasing that last high, that sensation. Addiction is a combination of psychological dependence, physical dependence, compulsive use, and tolerance. Obviously, someone who's addicted means they're doing it daily or weekly or regularly, and so you can see where it is constantly in their system and causing all of those 4 things. Patient becomes totally consumed with obtaining, using drug to the exclusion of all other things. The definition of an addiction is when an activity impairs your ability to function in society. Or when it starts, you're willing to, in family relationships, you don't care if you piss off your family members or your spouse or whatever, the drug is more important to you. Okay, that's when you're addicted, is when it is impairing your ability to be successful in other areas. Okay, ethyl alcohol, ETOH. So it's a CNS depressant drug. It is the most commonly abused drug in the world and in the United States. Okay, what it does is it decreases reaction time. This is where it, is bad for driving because it increases accidental trauma risk. Decrease social inhibitions. Okay, so this is a guy drunk at the bar hitting on somebody else's girl, so they get their butt kicked, right? Potentiation of other CNS depressants. This is a person who's depressed normally, taking an SSR eye medication, but then it's New Year's Eve and they don't have their date, so they buy a bottle or two of wine and they take their depression medication because they're worried about getting depressed, and now they're drinking alcohol and they're in a serious coma because the alcohol just mixes with the CNS depressants they're taking, and voila, they're in bad shape. So lethal overdoses in combination with other drugs, it has a synergistic effect. Slow GI tract activity causes irritation, gastritis, ulcer disease, GI bleeds, and eventually liver failure. And then toxic overdose, respiratory depression, and shock. This is where you drink too much too quickly, usually without eating food. This is what they call alcohol poisoning or whatnot, where you drink yourself to where you're unresponsive.
Besides antidepressants, what else?
Pain meds. Okay, anything else that has CNS depressant properties. So benzos, barbiturates, narcotics, most of your psych medications, when mixed with alcohol, they're going to have a synergistic effect where they are basically, because alcohol is a CNS depressant. So when you add it to the CNS depressants you're already taking, it magnifies the effect. So you shouldn't drink if you're taking any medication.
So antidepressants are depressants?
They can be. They're a CNS medication. They've gotten to where, and I said antidepressants, really it's psych medication. So if you're schizo or if you're bipolar, you're going to be taking psych medications. Okay. Most of those you cannot mix with alcohol. Okay, but it happens. They've gotten better, they've developed more and more. The SSRIs, I think, are the ones that are the best at this point. But it used to be you had to be on a benzo like Valium or a barbiturate, that type of thing, and those were really lethal with alcohol.
So it'll cause overdose quicker?
Yeah, it'll knock you out. Okay? Ethanol intoxication signs: breath odor, swaying or unsteadiness, slurred speech, nausea, vomiting, flushed face, drowsiness, violent, erratic behavior, altered level consciousness, obviously. So in the presence, so when you have these type symptoms, when basically you're altered because you've ingested alcohol, it makes it more difficult for your patient to be reliable, and it may mask other symptoms. So complicates your assessment, definitely, but especially, the person who's drinking and driving rolls their vehicle, you don't know whether they hit their head necessarily or whether they're just drunk. And are they ever just drunk? No. So we end up treating them like it's a head trauma and rushing them to the hospital, and they get a big trauma bill and all this stuff, and then we find out, they were just drunk. Other than that, they're fine. They broke their pinky finger, right? Diabetes, same type of thing, okay? You may show up on the scene of a wreck and think, hey, whatever. It could be their blood sugar, though. Drug toxicity, a lot of people, again, we may pick up on the alcohol, but they may have ingested other drugs as well. CNS infection can mimic ETOH intoxication and vice versa. So meningitis, okay, is an infection that gets into the spinal fluid, the CSF. Well, that can mimic altered mental status caused by ETOH type of thing. So again, the patient is never just drunk. We're going to take them to the ER. We're going to make sure that they're evaluated and make sure nothing else is going on. Okay, alcohol addicts. So they experience alcohol withdrawal syndrome if they reduce intake. This could be restlessness, tremors, hallucinations, becomes life-threatening when they start having seizures, and delirium tremens, or what we call DTs. All of the above plus tachycardia, nausea, vomiting, hypertension, and elevated body temperature. When they are detoxing or when they go into DT, this is when it's a serious life threat. Okay, and we have to treat them. So life-threatening condition occurs 1 day to 2 weeks after intake is decreased. So a lot of people want to stop their alcohol abuse pattern, so they'll say, well, I'm never going to drink again. And they do good for a day, maybe 2 days, maybe 3 days, and then they go unresponsive, convulsing on the floor with an elevated temperature and hypertension. Okay, and then they get sent to the hospital and they get fixed up and they go home and say, well, I'm never quitting drinking again, right? That was terrible. Okay, 5 to 15% mortality. What do we do for them? Same as we would do for any other altered patient. We're going to control the airway, try to prevent aspiration, and monitor for signs and symptoms of shock. Okay. Narcotics. Opium, opium derivatives, synthetic compounds that produce opium-like effects. So narcotics are pain medications, right? On the street, the most common one you run into is heroin. However, a lot of people deal, as you guys know, in prescription drugs, anything that can create a high. So opium, heroin, morphine, Demerol, Dilaudid, Percodan, codeine, Darvon, Talwin, all different medications. By the way, what do you guys see here? What do these pills look like? Describe them to me. Does anybody know what those are? So if you found this baggie in your patient's pocket, how are you going to know what to do for your patient?
Is that Oxycontin?
Could be. I don't know. Call poison control. What are you going to tell poison control?
They're small, round, pink.
Okay. I got some small, round, pink pills with the number 20 on them. And they're going to put that information in their database, and they're going to give you, well, it could be A, B, C, or D. Okay? And sometimes they'll know exactly what it is. Sometimes there won't be A, B, and C, D. Sometimes it'll just be A. But you're going to take that medication, you're going to call poison control, and you're going to try to find out what it is. You'll also check their house, their car, their backpack to look for a bottle. But sometimes this is all you get. You get a little baggie with pills in it. I've had it where there is no baggie. There's just pills in their jeans pocket. Okay. Narcotics. So obviously there's a lot of medical uses, analgesics, antidiarrheal agents, and cough suppressants. Pain. Treat pain. So symptoms or negative effects of narcotics, when they overdose, it can cause a coma or unresponsiveness, respiratory depression, which is how it kills people. It stops their breathing. And the telltale sign that it is a narcotic overdose is that they will have pinpoint pupils that are not reactive to light. Okay? So narcotics withdrawal, same type of thing we kind of talked about a little bit with alcohol. So they can get real agitated, anxious, have abdominal pain, dilated pupils, sweating, chills, joint pains, a real kind of goosebumps, bumpy. Resembles the severe flu. It is not life-threatening. They will not go into delirium tremens like they do from alcohol. They won't go into DTs. Okay? We're going to treat it basically the same way. We're going to support their airway and watch for signs and symptoms of hypovolemia. Okay, barbiturates, another class of drug. Again, generally these were used as psych medications. Seconal is one that you may see on your test. Hint, hint. Phenobarbital, amitrol. Anyway, if you notice, they all end in an AL. That helps you know that they're a barbiturate. These are not prescribed all that often anymore. Like I said, they've moved on to newer and better medications, but they are still somewhere out there. So induces sleepiness state similar to ETOH intoxication, used as a sedative or a hypnotic. Overdose, coma, respiratory depression, and shock. Extremely dangerous in combination with ETOH. It has that synergistic effect that we were talking about earlier. Okay. Withdrawal resembles ETOH. Withdrawal with DT is extremely dangerous. Okay. Same type of thing. Watch for those seizures, elevated temperature, body sweats, agitation, that type of thing. Barbiturate like non-barbiturates, so there are some medications that are non-barbiturates, but they cause the same types of effects. Overdose can cause sudden, very prolonged respiratory arrest. Withdrawal resembles ETOH, extremely dangerous. So Here's some names of them. Quaalude is probably the most common one that you'll see here. You may not always know the medication. You don't necessarily need to know this medication to know that your patient is going to be in respiratory depression, altered level of consciousness, and how to treat them. Okay? Most of this won't show up till you get to the hospital and they do lab work, unless the pill bottles are right there. And again, you can call poison control. They'll tell you what it is if you can identify it. You're still going to treat. You're going to treat the patient first. If you never identify what's wrong, exactly what they took, that's not the most important thing. The most important thing is that we're treating the patient. Okay? Tranquilizers. Again, these are benzos, so Valium, Librium, Miltown, just drugs. Low doses relieve anxiety, produce muscle relaxation. High doses produce barbiturate-like effects, meaning coma, sedation, that type of thing. Overdose, unlikely to cause respiratory arrest alone, however, extremely dangerous with alcohol. And then, again, they can have withdrawals from tranquilizers or benzos. Resembles ETOH withdrawal, extremely dangerous. Again, elevated temperature, nausea, vomiting, altered level of consciousness, seizures. CNS stimulants are amphetamines. So methamphetamine is the most popular one around here. We see methamphetamine. Release fatigue, promote euphoria, and reduces appetite. So a lot of these people use in diet programs, that type of thing, speeds up your heart rate, which speeds up your metabolism, which will make you burn more calories, all that type of good stuff. Overdose causes restlessness and paranoia, tachycardia, hypertension, which can lead to strokes and heart failure, and hypothermia, which can lead to heat stroke. Withdrawal is just the opposite of that. They'll be real lethargic and depression. Cocaine, a little bit different, stronger than that of amphetamines, can cause respiratory cardiovascular failure, heat stroke, or lethal arrhythmias. Cocaine has a more significant negative impact directly on the heart, causing VTAC, VFib, that type of stuff, and killing people outright. Cocaine powders that people snort, or they can get it in what they call a rock or crack cocaine. Some people, they get arrested by the cops. I picked up a guy from the jail who had swallowed 5 rocks because he didn't want to get busted by the cops. Got taken to jail anyway, but then started having some real crazy symptoms because he had 5 rocks in his stomach. Okay, snorting can destroy nasal septum, cause massive nosebleed. Again, withdrawal from cocaine or any stimulant is the opposite, which will be lethargy and depression. Hallucinogens, LSD is probably the most common one. MDMA is out there. Enhances perception. Wrong setting may induce bad trips with extreme anxiety. True toxic overdose is rare. It's not so much that they overdose on it and it's going to kill them by causing respiratory depression or whatnot. It's that they have a bad trip and they leap off a building because they think they can fly. Okay, or they decide to run naked through the streets. It's that type of thing that gets them in trouble and gets them killed. Again, it causes altered mentation, which increases trauma, and trauma what kills them. Same with alcohol. It's usually trauma. PCP or angel dust produces bizarre, violent behavior, reduces pain sensation. You guys all probably learned about Rodney King when you were in school, right? Ever heard of Rodney King, or is that too old? Probably learned about him. He was a gentleman, I believe, in L.A. Say what?
I think it was Compton, right?
Compton, somewhere, I'm not sure. In California. I don't even remember exactly what they were doing. I believe they were throwing bricks or something. Anyway, got into it with the cops. The cops could not control him because he couldn't feel pain because he was on PCP. So the cops ended up beating him up pretty bad. They went to prison type of thing. Okay, caused severe riots back in the day. But that's when PCP got a lot of public attention, which actually made it even more available. People wanted it more. But anyway, it's also dangerous because, again, people on PCP, they're violent and they fight and they fight and they fight and then they just die, dead. Boom. So law enforcement puts out a bunch of videos that when you have somebody who's in this type situation, they have certain rules that they have to follow as far as detaining them and how they position them, and somebody has to stay with them, that type of thing.
Why would they die from it?
They don't know. There's a lot of studies going on with the with these type drugs, and they're not sure. Not always. But there's unknown causes. There's studies out there trying to figure out what exactly happens. But they go through this enraged period, and there's been a lot of lawsuits type of things where the cops are like, well, yeah, I hit the guy. He was violent. He was picking up the car and throwing it, and I couldn't control him. All this stuff, and then all of a sudden he just fell over and he was dead. Like, I didn't hit him that hard. But there's been a lot of lawsuits, and there's a lot of studies out there trying to figure out why, and they're not sure yet. They're still trying to figure it out. Keep patient in quiet environment and minimize stimulation. Okay, if you have somebody who's legitly on PCP, good luck controlling them. I mean, good luck. You guys it's more than likely it's going to be law enforcement helping you out. People like to huff solvents, so glue, paint, gas, light fluid, toluene. I know we've had a lot of people around here huff the Freon in the AC units. They'll go through apartment complexes, all the little 14-year-olds, and they'll unhook people's ACs and they'll huff it, which makes them all kind of crazy. Inhalation produces a state similar to ETOH intoxication. Patient may asphyxiate if consciousness lost while sniffing, and it kills brain cells. Like if you huff enough, you'll be mentally retarded for life. Like it kills brain cells. So what does it do when you huff these substances? It literally replaces oxygen on your red blood cells. Okay. So your body stops getting the oxygen that it needs because it's being replaced. Okay?
Same with carbon monoxide.
Basically the same as carbon monoxide. Each one of these chemicals is going to have a slightly different, rate of attachment to the hemoglobin. They may not all be as highly affinitive as carbon monoxide, which is 200 or 250 times, whatever it is. These are all going to be slightly different, but they still replace oxygen. Okay? So increased risk of arrhythmias also. So it causes heart muscle irritability. They cause liver damage, bone marrow depression. Chronic abuse causes CNS damage, paranoia, violent behavior. It literally kills off brain cells. Okay, questions about drug abuse overdoses? Okie dokie. Y'all take a 5-minute break, come back.
Have you ever had a patient on PCP?
Have I had a patient on PCP? Not that I can definitively say. Have I had violent patients? Yes.
What do they mean by the superhuman strength?
Literally, one man can fight off 10.
Wow. And they don't know why?
Well, they know why. It's the drug. They don't feel pain. They don't know why these